Okay. So good evening, good morning, good afternoon to everyone, dependent on where you are in the world. I'm in beautiful Cape Town, so we are kind of ending off the day and into the evening, but I hope wherever you are that you are having a wonderful day thus far. My name is Bronwyn Green, and I'm the clinical training individual for Redress Medical. My background is as a wound care practitioner, and I have run my own medical practice for many years, where I've managed and treated a lot of the hard to heal, difficult type of injuries that we're going to discuss today. Now, the concept of wound hygiene is based in biofilm-based wound management, but it is a concept that is taking the whole wound bed principle and building and advancing on that. So without further ado, let's get going and let's look at what we're going to cover today. Now, wound hygiene is broken down into 4 particular steps, but they do run parallel or concurrently with one another. For the purposes of understanding the stepwise approach to wound hygiene and ensuring that we prepare the wound sufficiently in order for us to get the best clinical or therapeutic outcome from our dressings, we're going to break them down into 4 distinct steps. So just very quickly, what is the rationale behind wound hygiene, and why do we want to look at a concept such as wound hygiene when looking at chronic or hard to heal wounds? We're also then going to break it down into 4 steps. The first step being a good therapeutic wound cleanse, as well as managing the periwound area. The second lecture, or part 2 of the webinar series, is going to be looking at debridement. And when we look at debridement, what are we talking about when we discussing the hard to heal or difficult to manage chronic wound? We all, I'm sure, do this in our practice, but there's some interesting work that Randy Walcott has done specifically when we look at refashioning the wound margin. And when we look at the wound margin, what do we need to look at and manage from a biofilm-based wound point of view to ensure that when we put our dressings on, we are getting the best clinical outcome for our patients? And then the fourth one, which as long as we've done step 1, 2, and 3, and we've optimized the wound locally as well as the patient systemically as much as possible, how do we take our dressings and what we've achieved in the first 3 steps to ensure we get a good clinical outcome and get that patient to definitive wound closure? Now, I thought this quote here by Benjamin Franklin was very appropriate for this lecture, because by failing to prepare, we are preparing to fail. And I think that this is very apt and appropriate in the chronic or hard to heal wound market, because if we do not approach our wounds and prepare the wound bed to receive clinical treatment or to ensure that we get the best clinical outcome or optimize that wound to get the best clinical outcome from what we are applying, we are then dooming that dressing essentially to failure. So how do we go about ensuring that we prepare the wound bed to get the best clinical outcome? Now, this was a paper, Wound Hygiene is a paper that was published in 2020 by a panel of wound care experts that got together in 2019 in the UK, but the paper was published in 2020. And it looked at the whole terminology around the chronic wound. Now, they said any hard to heal wound is any wound that has failed to respond to standard of care. Now, there are many parameters that we can utilize as measurements to whether or not the wound has failed to respond to standard of care. But the cutoff is if by 4 weeks we're not seeing a significant reduction in PAR, or if the wound is not responding, that would be classified as a failure. We also then look at if we don't have a wound that goes through that 4-week period, it would be any wound that deviates from the norm with regard to wound healing. So we understand and we know what the phases of wound healing are. And in normal wound healing, it will be sequential and we'll move through all of those phases in a predictable, orderly fashion. So any wound that deviates from the norm would be classified as a hard to heal type ulcer. The other thing that we're wanting to change with regard to the terminology is the word chronic. And chronic implies that it is something that is always going to be there. There is no rush to manage or treat this wound because it's a chronic underlying pathology. And I think we need to, and what wound hygiene document tries to enforce, is the fact that we want to change our thought processes as it comes to chronic wounds. We don't want to just carry on doing the same thing and expecting a different outcome. We want to change our thought pattern to say, if the wound is not healing, it's not chronic, it's just hard to heal. So how do we adapt our treatment? How do we adapt our approach to these type of injuries to get them to definitive closure and put a little bit of urgency into how we manage? We know that there is a difference between chronic and acute wound healing, but how do we optimize it as much as possible? And the big concept that has come out of wound hygiene is obviously biofilm management. And regardless of what dressings you are utilizing, if we don't optimize and manage the biofilm, our dressings are not going to be successful. We will end up with a stagnant wound or a regression in wound management or in the appearance of this wound specifically. So what do we understand when we talk about wound hygiene and biofilm-based wound management specifically? Now, biofilm, we have known, exists for very many years, but we've predominantly kept it in the field of invasive devices. So central lines, arterial lines, endotracheal tubes, ET tubes, Foley's catheters, Vascats. And we said, because it's inert and it is a foreign body that we're putting into that wound, we'll keep it in for a certain period of time, 2 weeks, we'll remove it and resite it. Or if a patient shows any clinical signs, we'll remove it, send it off to the lab for MCNS, and we'll see whether or not we've got a biofilm growth on this wound or on this device. But we also get aspects of biofilm in everyday life. And one that you are all very well aware of is obviously dental plaque. And dental plaque is essentially a biofilm, and it does reform every 24 hours. And it is not on an invasive device or a foreign body that we have placed in the person's skin or an implanted mesh in the surgical devices. What we do know is, in order for us to manage biofilm in the mouth, we have to be repetitive. So 2 to 3 times a day, we will be abrasive with a toothbrush to break down and remove biofilm that might have adhered or accumulated on teeth. We will use a mouthwash, and we will also look at using a toothpaste as an antimicrobial. And we know that if we don't manage this repetitively, continuously, that biofilm will continue to grow and develop. And if we don't manage it appropriately over a period of time, we're going to end up with significant dental cavities. And again, if it's managed even more poorly than that, it does lead to significant systemic issues. There are multiple examples of this in everyday life. We shower to maintain a good normal skin flora, and we are abrasive as far as that is concerned. We use water, we use soap, and it is repetitive. The same as a healthcare provider, we are repetitive, abrasive, and an antimicrobial when we wash hands in between patients. And the same should be applying to wound management, even though we're dealing with an open wound. The concept here between biofilm-based wound management to ensure that we are getting an appropriate clinical outcome and managing biofilm is the fact that it needs to be repetitive. We need to be abrasive, and we need to be using something that is an antimicrobial to manage these patients. Now, I'm sure you're all very familiar with the term biofilm and what biofilm is essentially. But as a very quick overview, a biofilm is essentially a cluster of bacterial cells that are not necessarily all one species or another, but they work synergistically together, and they embed themselves in a protective matrix. And this is essentially what we would call an EPS, or a polysaccharide matrix. And this essentially creates a protective cocoon around the bacteria. It allows them to flourish, it allows them to grow, and it's unimpeded. No antibiotic and no patient or host defenses can penetrate this polysaccharide matrix in order for us to eliminate it, to be able to treat a wound to get to definitive closure. Now, what I'm going to do is just very quickly show you a video explaining how biofilm impedes or impairs wound healing. Please let me know if you can't see this or hear.
Biofilm can be defined as a community of microorganisms embedded within a self-produced matrix, attached to a living or non-living surface. Biofilm is everywhere and is the way microorganisms organize and proliferate. Biofilm has been shown to be present in at least 78% of chronic wounds and is now widely recognized as the primary cause of non-healing. During colonization, free-floating bacteria attach to a surface and begin to multiply. As they proliferate, they start to secrete a protective matrix made of hydrated sugars, proteins, and DNA. This is known as extracellular polymeric substance, or EPS. Within 24 to 48 hours, a mature biofilm can form. It quickly evolves, adapting to conditions and becoming more robust. Mature biofilm exhibits characteristics that can result in delayed healing. Microorganisms can sense and react to changes in their environment by communicating as a team. For example, an attack alarm signal can trigger certain bacteria to become dormant and more resilient to antimicrobials. EPS acts as a protective barrier and physically shields microorganisms from the actions of antiseptics, antibiotics, and the host's immune system. While these defenses are not able to breach the EPS, they are still effective against free-floating bacteria, contributing to a chronic inflammatory state in the wound environment. Biofilm can spread across the surface by releasing individual biofilm cells or by releasing new EPS-protected colonies. Biofilm is difficult to completely remove, even following aggressive debridement, and can reform within hours. Biofilm can be invisible to the naked eye, yet there are clinical signs to look for, such as inflammation, slough formation, and elevated levels of exudate and MMPs. To prevent biofilm reformation, effective and systematic biofilm-based wound care is essential.
So taking what they've just said into consideration, we have to acknowledge that biofilm formation in chronic wounds is a contributing or the most significant contributing factor to a wound being delayed in healing, stalled in healing, or not achieving definitive closure. And this is predominantly the longer the wound has been open, the more likely you are that you are dealing with a biofilm. Now, if we have a look specifically at what our understanding on the presence of biofilm is in chronic wounds, we originally would say the longer the wound is open, the greater the risk. We would incorrectly say, can you see that slimy surface on that wound? That's biofilm. Very often that is protein coagulum and not biofilm, because unfortunately biofilm cannot be seen with the naked eye. You can see some contributing signs or corroborative signs at the wound interface that you might be dealing with biofilm, but you can't diagnose it just by eyeballing or looking at the wound. We know the incidence is less when we're dealing with acute type pathologies. Now, there was a meta-analysis done, and that meta-analysis said if we look at chronic wounds, about 80% of all chronic wounds do have biofilm. So if we're looking at a wound that traditionally looks stalled or unresponsive to standard of care, and let's say we put an actigraft on and that wound is unresponsive or doesn't respond to actigraft on that wound, it could very well be because we're dealing with a biofilm. And as we know, regardless of what dressing we put on that wound, we are going to have an unresponsive wound until we manage that biofilm and optimize and disrupt it sufficiently. Now, the expert panel that has put out the wound hygiene document has stated that in order for us to get the best clinical outcome when we look at using our dressings, it's vitally important that all chronic or hard to heal type wounds, as we're trying to change the thought pattern and terminology, is that 100% of all hard to heal wounds do contain biofilm. And for this reason, all unresponsive wounds need to be managed as if they do have biofilm. Now, wound hygiene is essentially a concept that is building on something that is well established within the chronic wound market. And these are the three pillars of wound bed preparation. But it's taking those concepts a little bit further and being more aggressive as far as management is concerned. So if we look at what are the four concepts around wound hygiene, they are essentially that we want to cleanse. And we want to do a good therapeutic cleanse. Now, this deviates from what we have known as healthcare providers for a very long time. And as we work through it, I'm going to explain where it will change and how it will change. Obviously, we want to look at debriding that wound, and it needs to be multimodal. It cannot be a once-off surgical debridement. It needs to be repetitive. It needs to be multimodal. We want to manage that wound margin because work done by Randy Walcott, PCR testing, has shown that the highest concentration of biofilm is actually at the wound margin or in the peri-wound area. And then vitally important, we've done steps 1, 2, and 3, and we want to build on the momentum that we've achieved with steps 1, 2, and 3, and that is looking at dressing the wound. And when we dress the wound and we've done steps 1, 2, and 3, we open a time-dependent therapeutic window where we can get in with our dressings and we can try to manage biofilm. Because as you well know, we cannot eliminate biofilm, but we can get it to a point where it no longer interferes with wound healing. So if we have a look at that first step, and this is what we're going to cover today, is essentially what is a good therapeutic cleanse and what are the goals of a good therapeutic cleanse. When we look at wound cleansing, what should we be using in order for us to optimize that wound as much as possible? And it's important that we don't forget peri-wound. Very often we are very focused on what is happening in the wound itself, and we don't pay sufficient attention to what is happening in the peri-wound, because that as well can be a continual form or source of contamination to that wound. And we have a large population of lower leg ulcers that battle with hyperkeratosis or hyperkeratotic lesions within that lower limb. And we need to know how to manage that in the peri-wound in order for us to be able to progress this wound to closure. Now, our traditional understanding of wound healing is that as we trained, we want to be gentle. We don't want to be continuously aggressive because we'll damage neodermis, we'll convert the wound to a deeper depth of injury. So we will go in and we'll try and be as gentle as possible. Now, when we're looking at these chronic wounds or hard to heal injuries that have biofilm, we need to change our thought patterns. And the thought pattern is that that wound is a battleground at the moment. And if we are going to go in there with feathers, we're not going to achieve very much. We have to go in and be as aggressive as the biofilm is. So it's not going in and gently wiping over that wound. It is going in there and being abrasive and trying to disrupt the biofilm that is in that wound. As the wound starts to progress, we become less and less aggressive. But initially, we need a good therapeutic cleanse that is very aggressive. So let's take a look at this patient specifically. Traditionally, this would have all been left in place, and we would have cleaned over it, and we would have relied on a hydrogel or enzymatic debrider to manage and get rid of the remnants of what we see in the wound there physically. What we do know, though, is autolytic debridement and enzymatic debridement is ineffective in biofilm management. So we would sit with a wound that does not progress. So we need to change the way we approach these wounds. And by doing that, if we look at this as a case in point, I go in there with my gauze, I use an antimicrobial, and I'm very abrasive as I go in and I clean. And I want to essentially scrub as the patient can tolerate from a pain point of view to try and disrupt that biofilm that is present within that wound as much as I possibly can. And this is where once off is not sufficient. It does need to be a repetitive type of action. So if we look at therapeutic cleansing, what is it? Yes, I need to therapeutically cleanse the wound. And the function of therapeutically cleansing that wound topically is to reduce bacterial load within that wound, get rid of any residual dressing that might be a nidus for bacterial growth, obviously get rid of any devitalized tissue or debris that might be in that wound. But once I've done that, I'm going to take my solution-soaked gauze in an antimicrobial, cover that wound, and then in a pH-neutral soap, I'm going to manage my peri-wound, and I'm going to be aggressive in managing that peri-wound. So what I like to do is the foam from negative pressure. I keep a lot of the offcuts, and I will then take that and I will use a heavy scrub or pH-neutral soap, and I will wash and I will scrub and make sure that the flora on the skin is managed appropriately as well. Now, the rule of thumb for peri-wound is if it is a diabetic foot ulcer, anything from ankle to base of toes needs to be cleaned and managed. If it's a venous leg ulcer or a lower leg ulcer, anything from the knee to base of toes needs to be managed as a peri-wound. And if we're looking at any other type of injury, it would be anything that is 10 to 20 centimeters around the peri-wound. Anything that is covered by dressing needs to be managed, because those are all sites that can contaminate the wound and lead to additional biofilm formation within those areas. Now, obviously, this was published by Rodeheaver et al. In 2018, and it's looking specifically at what is the role of therapeutic cleansing. The role of therapeutic cleansing is essentially to use an antimicrobial solution, because normal saline, poor water, Ringer's lactate are ineffective as a therapeutic cleansing agent when we're trying to manage biofilm. It needs to be something that is antimicrobial in origin. We don't brush teeth with water alone. We use something that's abrasive with an antimicrobial to manage biofilm. The same principle needs to apply when we're looking at wound management and therapeutic cleansing specifically. Now, what are the reasons behind therapeutically cleansing? Obviously, we can't get rid of, not even surgical debridement in theatre gets rid of biofilm. It disrupts it. So we want to, with a good therapeutic cleanse, disrupt biofilm as much as we possibly can, so that when we apply our dressings, we can then start to attack and work with the biofilm to prevent its effect on wound healing. We want to obviously cleanse, that is self-explanatory, get rid of any protein coagulum that might be on the wound, get rid of any excess exudate. We also want to prepare that wound. Now, I've lost count of how many times I speak to clinicians, and their first is to take a wound swab, which we know the concordance rate is not great, less than 60%, but they'll take it before they clean the wound. Unfortunately, that is then not representative. So if we're wanting to do a wound swab to corroborate what we're seeing clinically, then yes, you need to do it to prepare for cultures or for wound swabs. You cannot adequately assess that wound until you've done a good therapeutic cleanse. And I'm going to show you in some pictures later in the presentation that if we'd not done a good therapeutic cleanse, we would have significantly undertreated the wounds. Obviously, any foreign debris, any remnant from a dressing, we want to utilize that to get rid of that on the wound surface. But also, we decrease surface bacteria significantly by doing a good therapeutic cleanse. Okay. Are there any questions thus far, or are we still okay? Ashleen, Alessandra? Okay.
There are no questions yet, Bronwyn.
Okay. So obviously we are dealing with an open raw wound, and there is going to be pain associated with this. And what I always say to my patients is that there are the 3 A's. It's not necessarily always the wound and working in the wound that causes pain. It can be environmental factors. It can be the perception that previously it was done and it was quite painful. So we need to anticipate that the patient is going to experience pain. We need to be prepared and either a local anesthetic or get the patient to have analgesics before they come in. And then we also want to assess what is their response to what we are doing. And there are many factors, psychological, environmental, that can affect their perception of pain quite significantly. It can be because it is procedural and we are working quite aggressively in a wound. But as the bacterial burden decreases, so this pain decreases quite significantly as well. Okay. And what I have found is if I sit with the patient and I explain significantly, this is what we're going to do, this is why we need to do it. They take analgesics on board. If they're very prone to pain, we'll use an Emler type or a lignocaine spray, lidocaine as you would sometimes call it, spray over that wound. And that is significantly sufficient to be able to work appropriately within this wound. If we're dealing with diabetic patients, very often they have absolutely no pain perception in that wound because they're neuropathic, and then you can work relatively easily within these wounds. This was just some of the gels and local anesthetics that one can utilize if you need to for patients. It takes about 15 to 20 minutes to work. So you would put it over the wound surface. You would use a transparent film such as a tegaderm and opsite, and then you would leave it in place and the patient would come back and you would then do a good therapeutic cleanse of this wound. The one thing we need to move away from is what I would call anointing wounds. And this is where we were trained to be as gentle as possible, to pour water over the wound, but that is ineffective as far as managing biofilm is concerned. And if we do this, our dressings are going to give us a suboptimal clinical benefit because we are not disrupting anything within that wound. Debriding agents are not going to be effective in managing that biofilm. So we want to be quite aggressive in how we go in and do a good therapeutic cleanse. There are different ways and different mechanisms in which we can achieve a good therapeutic cleanse. There's obviously pulsatile lavage and equipment that's available to us intraoperatively, but as an HCP in an outpatient setting, we might not have that available to us. Certain surgeons would use to do a good therapeutic cleanse on the wound surface and ultrasonic debriding agents, but again, that is not always available to all HCPs. The most effective that I have found in my clinical practice is I will take a piece of gauze and I will moisten that with my antimicrobial solution, and I will be quite aggressive as far as cleaning that wound is concerned. And while I do that good therapeutic cleanse, I'll have my forceps in my hand, or I will have a fork and spoon, and I will just be as aggressive as possible, taking the patient's pain tolerance into consideration. On the market, we do have new monofilament fiber cleansing pads, and these are very effective for people who are not very experienced as far as wound management is concerned and therapeutic cleansing is concerned, because any novice can easily utilize these to do a good surface therapeutic cleanse. What is important to understand is that saline and sterile water are ineffective as far as managing biofilm in a therapeutic cleanse is concerned. It needs to be an antimicrobial solution, and ideally research shows an antimicrobial solution that contains a surfactant, because the surfactant specifically has a mechanism of action against the polysaccharide matrix that cocoons the biofilm specifically. We want to ensure that if it is a sinus, if it is an undermined area, if it is a cavity, we want to have sufficient pressure behind whatever we're irrigating and washing out with. Dependent on what tissue we're dealing with, we can have a higher PSI if we are dealing with a lot of necrotic tissue within that wound, but if we have omentum or delicate granulating tissue that is starting to form, we want to look at a different or a lower PSI as far as irrigating these wounds is concerned. And then if you have a look on the right, it just gives you an indication of the size and volume of syringe, the type of needle to give you the correct PSI to ensure that you give a good therapeutic cleanse to these individual wounds. Obviously, there are risks associated with this to the HCP, and there are ways that we can try and minimize splashback onto the patient or from the patient's wound onto the healthcare provider. And again, what you can utilize will be dependent on what you have available in your facility. In South Africa, sometimes resources can be problematic. So very often we will take a medicine cup that patients get dispensed medicine into, we'll create a hole and we'll use that as our irrigation shield when we work in a wound specifically. So sometimes you need to be inventive, but again, you can utilize what is available in your facility. Obviously, a nice good pulsatile lavage would be done intraoperatively. Very good therapeutic cleanse, disrupts biofilm. What we put on post is then important. These are debris soft pads or debriding type pads, and I'm sure that you've all had exposure to them. They work very well, specifically in the hands of a less experienced kind of wound care practitioner. What is important is just to make sure that you moisten those pads sufficiently and you move them across the wound in a circular motion, and it's repetitive. It's not just a one pass across the wound, it needs to be repetitive. It can very safely be used in the peri-wound area as well, and very effective in the peri-wound, specifically when we're dealing with a hyperkeratotic or that hyperkeratosis. What I generally utilize in my practice and what works very well, whether you're experienced, a novice, or an experienced practitioner, is gauze. We all have it, it's readily available, and it doesn't escalate treatment costs significantly, especially if from a dressing point of view, we're going to look at using advanced therapeutics. We have to be very cognizant and we need to be aware of escalating treatment costs unnecessarily for patients. So yes, some patients might experience it to be a little bit more abrasive than the debriding pads, but it is a lot less expensive. It is as effective and can be used from novice to expert. Just important that we ensure that we are utilizing an antimicrobial liquid when we're doing a good therapeutic cleanse. Now, a good therapeutic cleanse, how much fluid should we be utilizing? Again, it's going to depend on the size of your wound. So if you're dealing with a large defect, it can be anything from 500 mils to a liter. Smaller defect, no less than 350 mils. So you want to get a good irrigation, you want to do a good therapeutic cleanse, you want to disrupt, and it can take anything up to 350 mils, dependent on the size of the wound. Now, what solutions can we utilize as far as a good therapeutic cleanse is concerned? What you can use will vary from country to country and institution to institution. So there are a lot available on the market. I'm not sure what is available in your market. In the South African market, Noxmaria, which is a buffered sodium hypochlorite, as well as Pontosan, which is the PHMB, which contains a surfactant, is used quite significantly in our markets. If we look at some of the markets over in Asia, microdicin is also utilized quite significantly. So again, as long as we're utilizing something that is safe, that is the right concentration for the right indication, you will be effective as far as a good therapeutic cleanse. There are papers looking specifically at just utilizing a diluted down iodine solution. And if that is all you have available to you, that is also going to be effective in managing the biofilm. Now, how does a surfactant work? Surfactants we like, and you will see that a lot of dressings say that they are anti-biofilm, and that's because they do contain a surfactant. Now, on a microscopic level on the wound, a surfactant has what we call a hydrophilic head and a hydrophobic tail. So microscopically on the wound, the energy causes this continuous, almost washing machine effect on the wound surface. And it traps wound debris, it attacks the polysaccharide kind of matrix around biofilm, and it allows us to start to reduce and eliminate biofilm formation within that wound, but it doesn't get rid of it immediately or completely. Now, as with antibiotic stewardship, there is obviously position documents out and available, and these position documents look specifically at antiseptic stewardship. And this would go to your iodines, your hypochlorous solutions, your PHMBs. What are we utilizing on a wound? And the most important thing that we need to look at is, what are we dealing with from a bacterial point of view within that wound? What is the concentration? Are we just allowing it to flow over the wound, or are we giving it an adequate therapeutic cleanse? And how long are we exposing the wound to this antimicrobial solution? Generally, it needs to be a 15 to 20 minute exposure on the wound surface in order for it to be effective. A 2 to 5 minute exposure is going to be ineffective as far as management of a biofilm is concerned. Now, if we have a look, and I said if we don't do a good therapeutic cleanse, then we are under-treating a wound. So if we had to have a look at this patient specifically that has a lower leg ulcer, if we don't go in and if we don't treat and manage this from a therapeutic cleanse point of view, we will manage just what we can see with the naked eye and what we've cleaned over. Now, this is all non-viable tissue, and underneath there we have a whole lot of open epithelium raw wound. Now, what's going to happen is exudate will track underneath there if we don't remove it, and we are then going to have something where we'll have festering of bacterial growth because our dressings cannot move through this non-viable dead epithelium or hyperkeratosis on this wound. So going in and doing a good therapeutic cleanse, I've now exposed the extent of the wound that I'm dealing with, and I can ensure that I have intimate contact with all aspects of the wound to ensure that the dressing that I'm using gives me the best clinical outcome. Now, if we start looking at the lower leg, and we will all in our practices see a lot of patients who suffer from venous leg ulcers, and we do get a lot of varicose eczema, and we do see a lot of this hyperkeratotic change on venous leg ulcers. And when it is surrounding a wound, it does become problematic because it contaminates the wound significantly. You can get exudate tracking in underneath those hyperkeratotic areas, and you then get ulceration, which causes to extension of the wound bed. So it's vitally important that when we look at managing the lower leg ulcer, it is not just the wound that we can see, which is a traumatic injury for this patient on the knee, but we're managing the entire lower limb as well, because the entire lower limb and what is happening on the entire lower limb will contribute to whether or not the dressings I'm utilizing is going to give me the clinical benefit I'm asking it to do. Okay. When we look at these patients, obviously there are consensus documents around, and these consensus documents specifically look at prevention, management, and maintenance. And if you do have time, there is a consensus document out by Wounds, and it's the management of the hyperkeratosis in the lower limb. And it specifically looks at ways and means that we can prevent and ways that we can maintain. I'm just looking at time, and we are running low on time, so I don't want to spend too much time on this, but we can open it up to question and answers at the end if that's something that you feel is necessary. Very quickly, if we look at a therapeutic cleanse, what is important? A therapeutic cleanse is important that we manage the wound as well as the periwound. When you have managed that wound, done a good therapeutic cleanse, you can cover the wound, and then using a pH neutral, something abrasive, you want to manage and clean. When we're looking at managing the skin, we want to keep it soft, we want to keep it supple. And what I would generally do is take a cream-based substance, put a thick layer on the lower limb, and put the patient under compression. And that managed that hyperkeratosis quite significantly or quite nicely. If we are looking at a diabetic foot, again, they battle with anhidrosis. So they dry out that skin, so that needs to be moisturized as well. Hygiene, very important in managing the wound, as well as the patient from a psychological point of view. So if the patient can go put a bag, cast cover over the wound before they come through to see you, that would be very effective as well. Okay. And I think that's us done from a therapeutic claims point of view. Any questions? Alessandra, Ashleen, anything from your side?
Nothing yet, Bronwyn. We'll give it everyone another second or two. It looks like we are all set.
Okay, fantastic. Well, thank you very much to everyone for attending. I do appreciate you taking time out of your day to listen, and look forward to seeing you for the next one, which is the exciting one, which is debridement. And how do we debride and prepare the wound so that when we put our dressings on, we get the best clinical outcome, and using that opportunity to get that wound to a point that when we put our dressings on, we get the clinical benefit we are after. Thank you very much.
Thank you, Bronwyn.